It is now my pleasure to turn today's program over to Charles Cluck. The floor is yours.
Thank you very much. Hello, everyone. Thank you for joining us. I want to welcome you today to our second webinar on the five-part care delivery orientation series. Today's webinar is focused on care management. If you're new to CPC Plus, please type in your questions throughout the webinar. We'll get to as many as we can. And for those we aren't able to answer, we'll provide additional information on CPC Plus Connect, as well as in the frequently asked questions section of the On the Plus Side newsletter. Our speakers today are Jen Miller and Joe Grundy, who are both members of the CPC Plus National Learning Team. Over to you, Jen.
Thank you, Charles, and hello, everyone. Thank you all again for joining us today for this webinar. We're really excited to welcome you and your practices to this second care delivery orientation webinar. This is the second of the 5 weekly webinars. In this series, it is meant to provide a comprehensive review of the primary care functions that will most directly impact your improvement efforts and are at the heart of your practice transformation. During each week of this series, the webinar will focus on a specific primary care function and will describe how your practice can implement high-impact change tactics to achieve the CPC Plus care delivery requirements. So today, we are focusing on Function 2, the care management function. And I will be serving as your primary facilitator today, and I'm joined by my colleague, Joe Grundy, also from the National Learning Team, who will be fielding most of your questions as you post them into the chat pod. We'll also be joined by 2 of your fellow CPC Plus participants, which I'll introduce to you in just a moment. They will be joining in on our discussion regarding various aspects of the care management function. And we will have some dedicated time towards the close of the session today for you to ask questions to both of them directly. And just as a reminder, the Q&A pod, or the question and answer tag there at the bottom, is a place for you to post your questions, and Joe will present those to the presenters at the end. And also, there are some downloads that are available for you in the file pod, and one is the presentation that you're seeing today, and the other is a document from the practice which we will reference during the presentation. So with this, I'm excited to start out by introducing you to Brittany and Melissa from the David M. Byron's Clinic in Marshall, Michigan. They're here with us today to talk about their journey with care management. So welcome to both of you, and thank you for taking the time to join us today. Could you start off by telling us a few things about yourself and your practice?
Sure. As she said, my name is Brittany, and I'm the office manager. We are a small private practice in Marshall. We've been in practice since 1989. Our office is composed of 1 physician and 2 mid-levels, with a patient population of approximately 4,500. We began incorporating care management back in 2012 with a Michigan-based program called MyPICT. We began with just 1 care manager, and now we have 3 trained care managers, so we can have care managers and care management services available at all times to our patients.
My name is Melissa Wilson. I'm an RN. I've been a care manager for about 5 years. Started out as a moderate care manager with MyPICT. Went through a lot of training, and now I'm happy to be working with Dr. Byron's group as a care manager.
That's wonderful. Thank you both for that background, and we look forward to hearing more from both of you today throughout the webinar. So I know that you've all seen this before and are starting to become more familiar with this diagram. This image represents the conceptual framework for CPC Plus, so we're going to take a few moments today to review it once again. So the drivers are the 5 key strategies that together support the CPC Plus goals of achieving better care, improving health outcomes, and being smarter about how we spend healthcare resources to achieve optimal outcomes. The primary driver, the comprehensive primary care functions, are in blue, and they are supported by the 3 foundational drivers, which are use of enhanced accountable payment in green, continuous improvement by data, which is in orange, and the optimal use of health IT in red. Supporting this comprehensive model of change is aligned payment reform in purple, outlining the entire circle. So all of you starting in 2018 have the added benefit of all that was learned during program year 1. So as we go through some of the foundational elements of the driver diagram, we will talk through some high impact changes that our 2017 starters practices identified. And of course, we know that a lot of you have already begun making some of these improvements. So some of this may be new to you and some of it may not be. So for those of you who have started to accomplish some of these goals, great work and keep it up. You'll also see that this model is designed to be flexible and allows you to prioritize your quality improvement work to best meet the needs of your practice and your patient population. One thing that we cannot emphasize enough is that there is no one correct, one-size-fits-all answer for any of these change processes. You, the participants from CPC Plus practices, CMS, and the members of the learning networks are all co-investigators in this work. We will all be learning from one another to identify what strategies are most impactful in making patient experience better, improving quality, and lowering costs. So as I mentioned previously, this series of webinars focus on the 5 comprehensive primary care functions, which are listed here on the slide. These are the aspects of practice transformation that will most directly impact the daily flow and life of your patients, your practice care teams, and your practice staff. You'll also see that most of the care delivery requirements reflect these high-impact change tactics that align with this driver. So each session of this orientation series will describe one of these primary care functions and highlight how they are interrelated. So during your first year, your practice will make some pivotal changes that will provide a foundation for the requirements of subsequent program years. One thing that I want to address up front with all of you, and that you will hear repeated often, is that CPC Plus is not a check-the-box compliance model of transformation. You and your practice teams will have to work together to figure out how to achieve transformational objectives so that they are achievable and sustainable in your practice dynamic. Also, there is no single correct answer for how you should transform, and we applaud innovation on any of these CPC Plus objectives. So here are some of the goals for this series. We've spoken to some of these already, but I'll quickly let you know by the time we are done with all 5 of these webinars, we will have described the comprehensive primary care functions to ensure you and your teams understand what the expectations for your first year in CPC Plus are. We also will have drawn directly from the experience and success of CPC Plus practices like the one you're hearing from today that started in 2017 to streamline your startup process. And finally, we will have identified key resources that you and your practice can use right off the bat so you won't have to reinvent the wheel. So, as I mentioned, today we're talking about care management, which is function 2. And so let's quickly review our objectives for today's learning event. We will be focusing on the requirements and key change tactics for care management, and you will gain knowledge and information to help you begin your risk stratification process and understand the different types of care management and ways to identify patients who would benefit from those services. Last week, we discussed access and continuity. Today we'll focus on care management. And care management builds on your work in paneling your active population and providing patients with timely access to care teams in ways that best meet the needs of your patient population. Care management is work with and for your patients. And generally, this work occurs outside of traditional office visits. Care management is a resource-intensive intervention and will have its greatest impact when it is targeted at those most likely to benefit from your services. Selecting patients for care management requires risk stratifying your entire patient population. And we will discuss the difference between the different types of care management, which are longitudinal and episodic care management. Let's start with a review of the care delivery requirements for this function. Care delivery requirements provide your practice with a framework for key changes that you will make in your practice. And these requirements are intended to be broad so that you can be innovative in your methods based on your resources and your patient population. These requirements establish the floor, not the ceiling, of practice transformation and innovation. That means that these requirements will provide you a rough structure to help coordinate your practice transformation, but do not serve as a minimum check-the-box requirement. These requirements will be updated on an annual basis, and they will build upon themselves as your practice continues to transform. This slide summarizes the clinical delivery requirements set for you in your first year in CPC Plus. Note that there are requirements that all of the CPC Plus practices must fulfill, and that's on the left side under Track 1. Then there are clinical delivery requirements that are specific to Track 2 practices. This means that if your practice is in Track 2, you will have to achieve those requirements on the left side in addition to those requirements on the right side under Track 2. So because this is so important, I'm just going to go through and clearly identify each of these requirements. So for Function 2 here, all practices must meet risk stratifying all impaneled patients. You will be providing targeted, proactive, relationship-based, or as we call it, longitudinal care management to all patients identified as being at an increased risk based on a defined risk stratification process, which we will be going over, and who are most likely to benefit from this intensive care management. You will also provide short-term, or what we call episodic care management, along with medication reconciliation to a high and increasing percentage of impaneled patients who have had an emergency visit or a hospital admission, discharge, or transfer, and who would likely benefit from this care management. You will ensure that patients who have had an ED visit receive follow-up interaction within 1 week of discharge, and also contact at least 75% of patients who are hospitalized in your target hospitals within 2 business days. In addition to these requirements, Track 2 practices are also required to use a 2-step risk stratification process for all of your impaneled patients, which again we'll review in just a moment. And you will use a plan of care for patients receiving longitudinal care management. All right, so on to the good, fun stuff to get started with risk stratification. So this is a fundamental process that builds upon empanelment and sets the stage for your care management efforts. These 2 concepts, empanelment and risk stratification, lay the foundation for all of the following strategies you will be implementing. These are considered high priority areas to focus your efforts as you get started. So this process of risk stratification allows your practice to have a population perspective and develop strategies to address patients at high and or rising risk, such as those with uncontrolled chronic conditions, high utilizations of the hospital or the ED, and maybe some psychosocial needs, while you're also going to be meeting the preventative care needs of your lower risk patients. So risk stratification represents a move from more of a reactive single provider approach to a more proactive team approach, and addresses the total health needs of your entire patient population. So simply put, it's a way to put patients into risk categories or tiers in a systematic, reliable, and organized way to get patients what they need when they need it. So even though we've started to talk about it, let's talk a little bit more about why do we risk stratify? What is the purpose of this process? This process of risk stratifying patients helps to identify the patients who are most likely to benefit from care management. So as we've talked about, you're empaneling your patients, you'll be risk stratifying those empaneled patients, and then you'll be then able to decide which patients would most benefit from care management services based on those steps to improve the health outcomes, reduce harm and waste, and reduce unnecessary utilization while decreasing costs. So your entire population of patients will be risk stratified into multiple bands of risk, each with varying levels of a response defined by your practice. This assessment allows your practice to develop strategies to address patients with high and or rising risk. And risk stratifying your entire population also helps to identify at-risk patients who might view you as their primary care provider, but they only seek you out on occasional acute visits. So that allows you to target them for more proactive preventative strategies. Risk stratification is an ongoing process. It's not a one and done, and this process takes time as you decide on a method and assign risk to each patient. So as you've seen from the requirements for this function, there are 2 ways to stratify your patients. Track 1 practices are only required to implement the first step of risk stratification this year, while Track 2 practices will be completing both steps 1 and 2 this first year. However, we have learned from CPC Plus practices that using a 2-step risk stratification process, regardless of requirements, is the most effective way to accurately assign risk scores to your patients. So what is the 2-step process? It's a combination of using an algorithm with a defined set of criteria in combination with clinical intuition. Let's start with looking at the first step, using an algorithm. Although there are some algorithms out there that have been developed that you can use, there is no one correct, clearly proven algorithm out there. So you will want to review those that are available to you, as well as those that maybe some of your fellow CPC Plus practices have developed. The method you choose to use is up to you, and you may find that you will create your own based on a combination of some of the other available methods. Some methodologies categorize patients into as few as 3 levels, low, medium, and high risk. And there's some that have as many as 7 levels. Regardless of the method you choose, all members of your care team should understand the risk stratification methodology that you select, and it should align with your care management strategy. Some of the criteria you may want to consider when developing your risk tiers are the diagnoses of your patients, certain high-risk chronic conditions, medications, hospital and ED utilization, and behavioral or mental health diagnoses. It's important that this first step be automated so your practice can use the power of the analytics to roughly segment the entire patient population as a starting place for the second step. So this next step, as a team, you will work together to review your patient's risk assignments to ensure alignment with the information that you guys know about the patient. So does that patient live alone? Are they unable to drive? Do they have behavioral health conditions that you're aware of, or any unmet social needs? So this step of adding clinical intuition, knowing those things about your patient that an algorithm may not know or be able to capture, is adding your care team's perspective to your patient's risk stratification process. The care team should have the ability to update and edit a risk score based on the professional judgment or any concerns that you have. It may be helpful to start this process with your highest and then your next highest levels. Once again, this is not a one-time process. It is important to recognize that a patient's level of risk is not static. Patients move in and out of risk levels regularly. Therefore, you'll want to reassess individual patients' levels of risk on a regular basis throughout the year, as well as distribute and look at the distribution of your risk score across your population to make sure that it represents your patients and the resources that your practice has. So I'm going to turn this over for a little bit so you can actually hear from our practice now that I've shared all this information, what this really looks like on the ground at a practice. So I'm going to invite Brittany and Missy back to speak with us and tell us about their risk stratification process. How did you get started? Which method are you using? And how did you choose that method?
Sure. We utilize an algorithm that was provided by the AAFP. Our decision to use this model was pretty simple. As we contacted our vendor, our EHR vendor, Allscripts, and that is the algorithm they have built into the system. So rather than fight against them, we felt it was a very solid algorithm, so we decided to incorporate that one, as well as then a high, medium, and low score based on provider intuition. The nice thing in our system is there's a simple drop-down that comes down, and you're able to assign that AAFP risk score, and then also assign the high, medium, and low. And so it's built right into the system, so it's easy to access, and then what it does for us is it then creates a little symbol that's color-coded next to the patient's name on the schedule. So it's a quick visual that we're able to kind of utilize during huddles in the morning and to identify who some people might be that could use some care management right off the bat. I encourage you in this process to take a deep breath. It's a little overwhelming at first. So what we did when we rolled it out is we began by just assessing patients at their physicals. This let our care managers have a little bit of time, get used to that algorithm, start to make it a little bit more comfortable, and then we rolled it out to all the patients once it was something they felt was no longer quite as time-consuming. I don't know, Missy.
No, and actually we had the algorithm printed, of course, that kind of goes through details, certain diagnoses, those high ones we're looking at, the high-risk patients. It lets us pick 1 through 5, 6, and then 6 being those nursing home patients that are super high risk. That's really all we do is help coordinate if there's some information that needs to be going back and forth between the skilled nursing facility. But we were able to just gradually, once you do 10 or 15 of them, it was pretty easy now the patients. I mean, we can look at their diagnosis, we look at their medications, we know if they're utilized in the hospital, and we can pretty much, all of us can just click those boxes and update that pretty easy without looking back at our algorithm and looking at our little cheat sheet. So it's really gotten easy through the year now.
Great. And I know that I have up here 2 screenshots that you use in your EHR to help you identify the risk score. Would you like me to go back to the previous slide and you can speak to what that looks like or how you utilize that?
Sure. This is just a look in the patient's record. When we first pull them up, this face sheet comes up. I've used a test patient here. And there's just a small icon sort of in the center that looks like a blue bullet point. When we click on that, this drop-down comes down with the AAFP, and you set the level. And then below the site risk, high, medium, and low, when you highlight that, you can also set that level. So it's very quick. It doesn't include a whole lot of extra steps. And then it incorporates that into the patient's chart.
Excellent.
And then in the next slide you showed, when we get here in the morning and log onto our computers, you can see all the little colored dots kind of in the middle of the page. The red ones are our high-risk patients. I mean, it kind of flags us right away. We can look at our schedule for the day. Oh, this patient and this patient, I'm going to be following up with them today. It really kind of lets us during our huddle to discuss anything new that's going on with the providers. And we know who we're going to see that day. And it really is just a visual, very easy on our EMR system to flag those patients.
Yeah, that's great because we know that we're doing this process and it's not just to check the box because there are so many benefits to risk stratifying your patients. And what you just shared, even at the practice level, to be able to get together in the morning and huddle and see what your day is going to look like so you can plan timing or resources that you might need based on those patients who are coming in with a quick glance like that, I think is really a great point to make. And so is there anything else that you'd like to share that you've seen the benefits of risk stratification in your practice for either your patients or your practice?
I think it's helped DMAs know they've learned also those high-risk patients, and they know who we're following. And if they have any concerns at all, or sometimes they will come to us and update us too. If they've groomed the patient, they'll come and say, you're probably going to need to see them today. They had no idea on their medications. Or you're going to need to see them, their cardiologist has changed their meds, and they don't know what they're supposed to be taking. So it really has helped, too, I think, even the MAs and everyone in the office to know those high-risk patients. Because they don't always know all their diagnoses, and they don't know that they've always been in the ER, or they've called us, and we've been talking to them. So that does kind of flag those patients for them also.
And that risk stratification level allows me then, from the administrative side, to pull reports. So I will pull our highest level patients, our patients that are in the category of 5 or 6, pull those reports and give them to the care managers just to make sure that nobody falls through the cracks. Nobody didn't schedule a follow-up or canceled something. It's just a nice reminder to pull those patients and make sure that they're in and that we're continuing and working with them so that they can hopefully get on track.
Exactly. You make some really great points there. And a lot of what we're talking about relates to the importance of working with your health IT vendors and having that workflow and functionality. So, I mean, as we've been listening to Brittany and Melissa talk about the importance of having this functionality in their EHR, I want to point out that they're so critical, they're such a critical component to the development of your risk stratification methodology. Some vendors provide guides and tutorials on the workflow and functionality for capturing and reporting risk levels, a lot to what Brittany was just speaking to. But on this slide, I just want to give you a few questions to think about as you're evaluating the effectiveness and efficiency of your health IT capabilities. It's really important to clearly develop that relationship with your vendors to understand their capabilities as you develop your workflows to optimize your process. So with that being said, I'm going to go ahead and over the past year, we've had some commonly asked questions around risk stratification, and I'm sure these might be some questions that are on your minds too. So we picked a few to run over with you guys right now, and the first one is, what are the differences between the risk stratification score that we're doing in this risk stratification process and then those risk scores that are used in our payments. So as we talked about, the risk stratification is a dynamic process that includes your entire population of patients, regardless of their payer or their insurance status. That process that you're doing helps you to provide targeted care to your patients, whether it be intensive care management for your high-risk patients or meeting the preventative needs for your low-risk patients. This score that you assign may differ from the risk score CMS assigns for the purposes of payments, and that score that CMS assigns for payments is used to determine the payments for your attributed Medicare patients only. So, oops, sorry, there was the answer. I'll leave it up there for a moment for you. And the second question we have that was commonly asked is, how often should you update the patient risk score? Now, we talked a little bit about this previously, but I just want to reiterate that it is at your discretion to determine how often you reassess your patient's risk score. But the risk score could be reevaluated at every visit. It could be every 3 months. It could be every 6 months. But at least annually for every patient, your entire population should be reassessed. And you may determine that certain clinical events like a hospitalization or a change in diagnosis or a change in medication may warrant a change in the risk stratification. So you'll just need to decide for your practice the best way to reassess, basically to ensure that the patient distribution across risk categories is accurate for your patient population. So I'm going to, at this time, I just wanted to take a moment to share a little note with you guys about this webinar. And I think I just wanted to make sure, because I'm realizing we're giving you a lot of information, and I don't want you to be overwhelmed. So this webinar is meant to provide you with an overview of these concepts as you get started. And there will be plenty of opportunities to dive deeper into these topics throughout the year. So I do not want you to think that you have to know all of this today. And hopefully this information is providing you with some ideas to get you started. And hearing from Brittany and Melissa gives you some confidence and excitement about the work that you're going to be doing in CPC Plus. Brittany and Melissa, would you have anything to add to that?
Oh, just that everyone out there that's just getting started, we kind of talked previously, but you know, it's a big process and it's a lot of changes, and it's important not to try to tackle the whole thing all at once. Take a deep breath, do it one step at a time. You don't want to burn out your staff members by trying to throw 100 things at them. So pick the things that are important to you and get started there. As I said, you know, we started by just doing physicals, and then they found that process became much easier. So then it wasn't quite as stressful when we rolled it out then to the whole patient population. So, you know, give yourselves a little credit and you'll get there.
Taking it one step at a time. Thanks for sharing that. Did you have something else to add, was I hearing? Nope, okay. Before I move on, well, now we'll move on to care management here, because we've been talking about risk stratification, and we know that that's a critical first step to prepare you for care management. So once you've risk stratified your patients, you can identify those patients who would benefit from both longitudinal and episodic care management. So briefly, these two types of care management are longitudinal, which is targeted, proactive, relationship-based care management, versus episodic, which is short-term care management based on event triggers. In longitudinal care management, practices identify and target high-risk patients by using care managers to proactively monitor them, coordinate care with specialists, work with community-based services, and provide self-management support, and use a personalized care plan that includes patient goals and takes into consideration the patient's values and priorities to guide their care. Whereas episodic care management is based on event triggers, such as a transition of care or new diagnoses of a major illness. These care management services are typically short-term and irrespective of risk status. In episodic care management, practices obtain information from hospitals and emergency departments on patient admissions. Care managers follow up with these patients within a designated period of time, as described in the requirements, and provide services focused on medication reconciliation, coordination with specialty care, home care, and or other community-based services. So we're going to dive into each of these a little bit further right now. So we're going to start off with longitudinal care management. So as you risk stratify your patients from low to high risk, you'll see a direct relationship to the cost and health status of your patient. Typically, as your health status declines, overall healthcare costs increase. Most practices target their higher risk patients for longitudinal care management services, as we talked about, that are more relationship-based and provide proactive support via ongoing, regular touch points with these patients, which is guided by a plan of care. These services are generally provided to patients with some combination of multiple comorbidities or complex treatments, frailty, and or functional impairment. These patients may also have behavioral or social risks or serious mental illness. These patients will probably be represented in your higher risk tiers of your algorithm. So I'd love to hear from Brittany and Melissa about your longitudinal care management program.
Sure. As I stated, we've got 3 care managers in the practice. They all received their training initially through that previous program, MyPicked, and they stay up to date by doing trainings with our provider organization and through a website, micmrc.org. I think it's Michigan specific. But one thing that we do that I think has helped make care management really embedded in our practice is all of the care managers have some dedicated care management time, but that's not all they do. They also room patients. They answer phones. They're part of the day-to-day patient flow. So when a care manager starts to work with a patient, for the most part, those patients know the care manager already. They have a history with them. We have a relationship with them. And so it helps that transition go smoothly and for them to have, I think, a level of trust with that care manager. To identify patients for longitudinal care management, the first thing we did is we looked at that AAFP algorithm, and it sounds like there's a little confusion. Our system doesn't automatically restratify them. It's a chart that we work through, and we set those scores, both the AAFP score based on those criteria, but then the high, medium, or low. So we can adjust those scores whenever we want to. For our office, we do it at physicals, so at least annually, and then upon any event, something like a hospital admission, an ER visit, a change in diagnosis. And another thing we can do that works well to keep the care managers as part of our office and part of the continual workflow is none of the care managers just have specific people that only they are working with. There's patients who have preferences, but they all share one inbox within the EHR. So anyone in the practice can send them a message because it may be the front desk found out they have a problem with transportation. So we felt that they would benefit from having some care management and some connection to resources. So then that way that message goes to all the care managers. So no matter what day it is, if a patient calls in, they all know where that patient is and they're able to keep working with that patient and keep that continuity of care.
And we all chart care. We have a care management section in our EMR. So we can look and see, if Renee talked to a patient yesterday and she happens to not be here today and I'm coming in and getting a phone call from the patient, I can look up her notes, see where she left off, see what they discussed, and it saves me a lot of time because I can pull those notes up. I know where they're at, and we also work very closely in the same we are literally maybe 10 feet apart. So we can all talk and we all kind of update each other as something significant going on in these longitudinal patients. We all track our ERRs and our hospitalizations. So we actually all kind of work as a team with these patients. Definitely they get to know one of us that they talk to the most, but they also know on the days I'm not here. I've told them, you can call Renee or Joyce or me if I'm not here. Any of us can help you with us. So we kind of focus as a team.
That's wonderful. I was just going to comment on that, how you get your patients familiar with this program and get them on board and understanding your role as part of the care team to establish that trusting relationship with them. That's wonderful. And maybe, that would be a great segue to maybe share with everybody else if you have maybe a specific story or some general examples of things that you've done to enhance that relationship with your patients. And I know, speaking with you, Brittany, you sometimes think, or Melissa, that you think your work seems quite simple and you're maybe not providing a lot of great care to your patients, but you are. And I love hearing your stories. So can you share with everybody a little bit about what you've done to make an impact on your patients' lives?
Sure. Just recently I have an elderly couple, and her husband had chronic leukemia. And they had just got they just got told that he had an oncology appointment coming up in Kalamazoo, and it was going to be about a 45, 50-minute drive for them, and that he could possibly need to start chemo again. And she was in for her well visit with doctor and broke down and was a little tearful for him. And he said, Missy, would you just go, if you have time, go sit down with her and see what's going on? I really don't know everything that's going on. So during our talk, several things she brought up, and we talked through them, and I just listened to her a lot. She did break down, and she said, I just don't know how we're going to make that trip to Kalamazoo. And I said, well, there's care managers there. I said, why don't we call them and ask if, sometimes treatments can be done at other facilities. You might have to go there, once every 3 months, or maybe that doctor would come closer. And she said, really? They do that? So I said, sure. I said, you have an appointment on Monday. I said, I will call care management. I will ask them to meet with you when you're there on Monday and see what we can do to coordinate that care. The care manager called me back Monday afternoon and said, Missy, thanks for your call. I want to let you know that the patient is going to be able to go right there to Marshall to see the oncologist. Right now he's stable, will not need chemo, but they are very happy that they don't have to drive so far. The patient has praised me up and down to Dr. Byron's and told how much I saved them and how much I helped them. All I made was a phone call. But I do feel for them, they're elderly, and that was a huge thing. But it was just something that I do every day. So I really didn't want to take that much credit. All I did was make a phone call, but it impacted their life.
Absolutely. And thank you so much for sharing that, because you as the care manager, you're at the heart of care management. I mean, you're the staff that provides the care management services. And some practices call their care managers by different names: care managers, care coordinators, patient navigators. You can have a wide range of backgrounds, from registered nurses to LCSWs. Sometimes an MA can provide those episodic care management support services. And so we listed here a few of the essential components of the care manager's role and responsibilities for providing care management for your patients. And so I'll give you a moment to look these over. And I'm curious, Melissa, if you might add to this, or if there's anything on this list that you think is if you were to pick one or two really critical components of this role that you find that is a big part of your job, what would that be?
Well, I look at that as, I network with a lot of care managers also. So, we go regularly to meetings through our PO, and we are constantly updated on the recent community resources and how we can refer patients and those resources that are available. And when I don't remember something, I know I can go to Joyce. I can also have a close relationship with other offices. I can call them, hey, what do you think about this? Do you have any resources that I'm not thinking of? So that network is very important with the community resources. And then even Joyce and Renee working closely together. We all track those longitudinal patients, those high-risk patients, and we're able to meet with them in a timely manner. We get them in. We are here. We're here. We're available. They know to call us. So many of our patients call us and say, this is going on. I think maybe we'll go to the ER. We're able to get them in the same day for a follow-up appointment. So our patients are very good about knowing if they call, they'll get seen if they need something's going on. There are some patients we say, yes, you need to go to the ER. But just being able to work with our patients so closely in many roles, we know our patients well. And so coordinating their care, we are able to just talk to them. What is it you need? Pretty much Dr. Byron has introduced care management to every elderly patient that's come in, just to let them know. So our CPC Plus patients know care managers. If they were in for a physical this year, guaranteed they know that we're in the office and the services we can provide. So just introducing us and getting us familiar, our patients know they can call if they have something urgent. And we have those resources. We do use a Connect website for the community links. So we do have a tracking system. We can track our our referrals for community resources. Also, they are really good about letting us know that they've received our referral and these services have been put in place. They've contacted the patient. So we do have a closed loop with our resources and our referrals. And then, like I already brought up earlier about we can follow each other and we know what we've done with each patient because our notes are right there under our care management section. So I can see who Joyce has worked with, who Renee has worked with, and I can update the risk score, I can update our care plans, because everything's been initiated.
And you brought up earlier that a huge component is making sure that your providers are on board, making sure that they're referring to you, that they're doing those warm handoffs, that they're in the system and they're part of what's going on in the office with the care managers.
And our huddles really help with that too, because we're able to look at our schedule. We're able to have that time with the provider, where that gets very hectic during the day. But we do have that time that we allot. Twice a week we have a care management time where we can meet with the provider and discuss patients for that week. So we do utilize that often and get to conversate with him on anything we have going on, and he can also update us.
Those are all really great points, and I love that you've shared that with everybody. So thank you for that. And I know we'll be touching on this role in just a few moments in a couple of slides as we discuss the role of the care manager just a little bit more. So I'm going to move us along to a couple of frequently asked questions around this topic that we've received in the past. So we're commonly asked, how many patients should we assign to each care manager? Well, that right size, there is no one right size fits all. And a lot of research will say that between 100 and 250 patients in longitudinal care management per full-time employee is accurate. And then I hear from other practices it could be a little bit less. So at the end of the day, this is up to you and your practice based on your patients and your resources. A second question that we receive is, what credentials, and this is kind of in line with what we were just speaking about, and experience should I prioritize when hiring a care manager? And basically, practices have the flexibility in staffing their care manager positions, and typically care managers come from nursing or social work fields. It's important that you are trained or that your care managers are trained to manage your patient's complex health needs. And oftentimes care managers are trained in self-management support, shared decision-making, and motivational interviewing techniques. And there is a download available that both Brittany and Melissa have shared graciously with all of you. It is their practice's care management policy, and even in that policy, it shares at the end some of the training skills that they require for their care managers, in addition to processes around their care management activities in their practice. So I encourage you to take a look at that, and thank you, Brittany and Melissa, for sharing that resource. And one last question that we receive that's common is, can I use the care manager based at a health plan to provide care management services for our beneficiaries? Well, to answer that question, you all know that care management is most effective when the care manager is fully integrated into the care team at the practice. It's important that your care manager builds relationships and trust with both practice and the patient. And care management services should be offered to all patients regardless of their payer. So I don't think I need to reiterate anymore, because we've heard such great testimonials from Melissa and Brittany about how true that is. The relationships that they've had have prevented unnecessary ER visits and have really improved that relationship, and having them there at the practice has really contributed to that. So now we're going to take a look at our last piece here, which is the episodic care management, and then we'll have some time to ask our presenters some questions. And so those patients who don't otherwise receive longitudinal care management may receive short-term or episodic care management services. Episodic care management encompasses a broad range of services designed to promote the safe and timely passage of patients between different levels of health care and across different settings. These services are provided to patients experiencing a wide range of conditions or events. And some examples include patients who've had a recent ED or hospital visit, patients who've had a new diagnosis or injury, or an exacerbation of an illness. those who are starting a new medication or who were previously on a medication but now they're unstable on a high-risk medication, and also those patients who are maybe just going through a life change. They may also benefit from episodic care management services. Your contact with these patients may be frequent initially, but will be short-term in nature with a resolution once your practice addresses that triggering event. The care team should work with the patients engaged in episodic care management to determine the timing and setting for their regular follow-up, whether it be by phone, email, or in person. Some patients will only need care management services for several weeks or months, while other patients may transition into longitudinal care management. So these are some of the possible key elements that would be that you would be involved in when you're doing episodic care management. It may include medication reconciliation that we just talked about. It will always involve the entire care team and coordination of services. I'd like to hear from Brittany and Melissa about their episodic care management services and what components, possibly including these on your screen, are incorporated into your episodic care management.
For patients that were in the ED, we do try to get them in our office for a follow-up within 5 days. I mean, some are, if they break their leg and they're going to be seeing orthopedics, we definitely want them to see orthopedics. But just update us if they need any help with coordinating that visit. We are here to help. But really, it's just to let them know. We also let all of our ED utilizers, let them know our open access hours, our Saturday open hours, our doctor on call after hours, so that some of these patients aren't aware of that. Or they didn't think, they knew it was after 5, so we were closed. Or they didn't realize that 2 days a week we are open later. So just reminding them of that. I mean, parents have a lot to remember. So even those young kids that fall and have a laceration, we can do that in the office also. So they don't have to run to the ER and sit there for 4 hours. We will get them in. If they showed up at our door, we would fit them in for an appointment. So just following them, letting them know we are available, trying to reduce the number of patients that go to the ED if it's office appropriate. And then we're able to pull the discharge summaries right away. We utilize a web portal called Patient Ping, which is Michigan-based right now. I do know they're working towards expanding that. We do have one Florida hospital that is also involved now. But it lets us know any patients that are attributed to Dr. Byron. It will send us an alert every day. We can log in, and it'll tell us all our patients that were either admitted into a hospital, in an ED, in a transfer to a nursing home. It lets us know anywhere in Michigan. So we're able to pull that right away, and then we can work with the hospital or get into the hospital systems and pull our ED reports if we need to. A lot of times those are sent right directly to us.
We have good relationships with 2 of the local hospitals. One we're actually located on site, so that makes the communication quite easy. And then the other one is in the area. So we're able to access their records, and we are able to work alongside them to make sure that we are aware of the patients and then are getting those notes so we can do that med reconciliation, so we can make sure that if any tests were recommended, any referrals, any of those sorts of things, we can make sure that then we're a part in that, so that everything that was recommended gets done, and then it's accurate in our chart so that we can work with them.
And and we have kind of a template that we use when we call our ED follow-up. We ask, were you given any new meds? Were any of your meds changed? Were you able to get your medications? Example, an antibiotic for cellulitis, were you able to get that? Just really important to follow up and make sure the patient didn't have any questions. They understood that ED visit and that discharge, the discharge follow-up plan, just to prevent them from going back. And that's why we do try to schedule appointments right away when we have them on the phone. We can transfer them and get them in. Also, just being able to follow up on testing when they're discharged from the hospital. Sometimes there's some disconnect with discharges and follow-up and the patient understanding everything. I've learned from even family, a patient, they get told a whole page full of information, and they only caught that first couple sentences. So definitely following up with them and making sure we're able to educate them on the discharge, a new diagnosis, the new meds, and follow up on any possible side effects, get the med rec in, all those things. So care management is a huge part of that. I even worked on the hospital floor for a lot of years, and just to see how med recs can go wrong so easily. So we try to make sure we are right on top of that.
And from a big picture perspective, our PO is a big part of our being able to work with our ER utilization and our hospital inpatient. They help us look at our numbers and see maybe if there are a certain reason that a lot of people are going. We did some surveys through our provider organization, and we're able then to do some outreach to the schools. We found that the coaches were just telling the kids to go automatically to the ER, or patients didn't realize they could call us during the day and come in. So from a big picture standpoint, our provider organization and working with them has helped us then incorporate some changes or some educational points to our patient population as a whole.
I cannot thank you guys enough for how much information you've shared with everybody, and I can only imagine the questions that are coming across everyone's minds. And I just really, everything that you touched on with this episodic care management is so crucial, and you make it sound, a lot of times when I'm speaking with Melissa, she makes it sound like her job is easy, but I just listen to everything that you're doing, and you're providing such a great service and following up with those patients and preventing medication errors or not having follow-up tests and making sure it all happens is really adding to that decrease in costs and better outcomes and less readmissions with those patients. So I want to thank you so much. And for the sake of time, I'm going to move this over to Joe for a moment and see if he can pull in some questions that I think have been feverishly typed into the Q&A pod over the last 50 minutes. So Joe, you want to pull out a few questions to ask these guys?
Absolutely. Thank you, Jen, and thank you to our practice presenters as well. So we have a number of questions. The first that I want to bring to your attention is how often do you call or your practice call higher risk patients that you've identified? Once a week, once a month? Is there just a standing process for that?
There are some codes where we can do longitudinal, but quite honestly, we're pretty busy here in our office. Our office is a very busy practice. We see 56 to 75 patients a day. Not all those are high risk, but we're pretty busy. We do make sure when a patient leaves, they know they have a follow-up in 3 months, and that appointment is made at the time they're here in the office. So we also follow gaps in care. So if we have our diabetics, our COPD patients, anybody that really is a high risk that we're following, making sure they're coming in the office. So as far as calling them follow-up, if we know we're working on something and there's an episodic event where we are following up, yes, we send ourselves reminders to make a call to follow up. We can do that through our system, send ourselves a little message. It'll pop up. We can pick the time and date to pop up, and we know we're calling. We knew that patient had a cardiology visit on Monday, so I'm going to call them Tuesday afternoon and follow up and find out about med changes. So I can send that to us. It's more episodic where we would plan on calling them in a certain amount of time, but otherwise we just plan on following up when they come in that office visit.
Thank you. So given that volume, actually, the next question is really relevant. One of our participants asked if you have any standardized key performance indicators for kind of evaluating the performance of your 3 care managers. Like, how do you assess their performance over time, other than just straight up volume?
Well, that was a little bit tricky because each care manager doesn't have a set list of people assigned to them. So overall, I monitor the amount of care management codes being billed, and I take a look at, they keep a lot of tracking within the office as to how many patients they're reaching out to and follow up. But in general, as we said, we're a small practice. I hear what they're doing, and I know they're working hard, and I'm physically able to see all the different phone calls, the outreach, the patients that are coming in just to talk to them. So I don't really have to run any sort of metrics beyond just doing those, running my reports for the care management codes. Additionally, just making sure that as a whole they're meeting their numbers for the percentage of Blue Cross Blue Shield, the percentage of priority. All of those sort of metrics that are built into the system really tell me whether or not they're actively engaged with the patients, and they most certainly are.
Well, and one thing, too, is I have peers I have to answer to. So if I'm not doing something, well, my peers are going to know. So I'm going to do the best I can to work with this team and make sure I'm doing my part. So like I said, we all sit closely together. We do know what's going on with our patients. We work very closely as a team. We also have had a lot of training. With our PO, we also talk about charting and requirements, and all of us are 5+ years now in care management. So we all are making sure we're following those code guidelines and are very cautious because we definitely don't want to be fraudulent in any way. So we're very cautious on how we chart, what's needed to be included, and we all are accountable to each other here in our office and to our provider.
And I can spot check them. I have done that in the past as an office manager. We had an outside care manager working with us that was not adequately documenting, so that had to be addressed, and that was pretty obvious. But yeah.
So we have time for about one more question, and I apologize to everyone that there's always more questions than time. We will follow up to this session. We will post questions on CPC Plus Connect with the answers. So if you don't have a question answered, please make sure that you contact CPC Plus support or post it on CPC Plus Connect, or just kind of continue the conversation. So last question then for our speakers. Once your team has a score developed through the AAFP tool entered into Allscripts, how are you or the care team modifying the score to account for clinical intuition? Is the clinical intuition automatically calculated into the risk score? Well, I guess manually in your case, but is it built into the AAFP tool?
No.
It's a two-step process.
Yeah.
And I don't know, did you share like the criteria for each risk and the risk for the high, medium, low? I know there was a little brief, one of the slides showed that two-step algorithm, but it really is pretty detailed, the paper that we have. If you looked up the AAFP, I don't know if you could just find that online because I think it's a charge to pull it, but it's very specific. So whenever there's a change, if they had a hospitalization and they're coming in for a follow-up, we would do it at that follow-up. If there's something the care manager is working closely with, we will update it. So it's updated as needed, but at least minimally annually.
And that high, medium, and low is based on our intuition. It is just that the providers, the things that wouldn't be included in there, such as family history, this patient has a tendency to do, to not show up for appointments or to not follow a care plan. So those sorts of things. So those scores are never really added together. They're always separate from one another. The symbol that goes on our schedule is the high, medium, low. So that's based on where we see them as a practice. So I hope that clarifies a little bit.
Yes. Thank you both so much for your time. We're almost at the top of the hour, so I'm going to briefly go through. These are our upcoming events to finish out this series of webinars, as well as an office hour at the end of February. And I just wanted to let you all know that there are so many resources available to you, and we encourage you to review the change package and the care delivery requirements. And also watch for the new implementation guide that will be coming out soon. We also encourage you to attend other learning events throughout the year. We have action groups, affinity groups, practices in action, and as always, we encourage peer-to-peer sharing. CPC Plus Connect is a great place to do that, and so we welcome you all to jump on there and start sharing. So we value your feedback, and our intent is to always keep improving these events, and your evaluation helps us to change and improve these events. So you have an evaluation that's being pushed out to your screen right now, and it will take less than 2 minutes to complete. And so I encourage you to please fill this out, and remember to keep the conversation going on CPC Plus Connect. As a reminder, we'll be providing instructions for accessing the credit for this event on CPC Plus Connect when it is available. And thank you all for joining us today, and especially to you, Melissa and Brittany, for sharing all that you are working on with care management. Greatly appreciated. Thanks, everyone, and have a great afternoon.
Thank you to all of our participants for joining us today. We hope you found this webcast presentation informative. This concludes today's web conference. You may now disconnect.